Now we are going to move on to the next lecture. We are fortunate to have Dr. Nikhil Kamath, a senior consultant and consultant radiologist and the head at the Jupiter Hospital and Imaging Center, Mumbai, a participant in the all multi-center study for characterization and tabulating the differences in COVID presentations across populations in India. He has rich experience with radiography in COVID, despite being in the private sector in Mumbai, with a caseload of not less than 50 HRCTs per day. He's been doing it for the past 7 months. A DNB teacher and guide at the Jupiter Imaging Center, which has all modalities including a 16-slice CT and 1.5 T MRI. He will present his experience in this forum on radiology and COVID-19. We welcome you, sir, Dr. Kamath, for your presentation on the imaging in COVID.
Good afternoon, everybody. Thank you for the introduction, Dr. Sujata. Myself, Dr. Nikhil Kamath. I am a radiologist at Jupiter Hospital and Jupiter Imaging Center, Thane, Mumbai. And I am going to speak on radiology and COVID, possibly because radiology plays a very important role in diagnosis as well as management of COVID. So in my next talk of next 10, 15, 20 minutes, I'm going to break the talk into 3 parts. One is I'm going to talk on the logistic issues in the radiology department. They are the common issues which everybody face, but I will be specifically speaking about the radiology department, what issues we faced. Then I would be speaking about the radiology features, basically pulmonary as well as extrapulmonary. Pulmonary forms about 90 to 95%, whereas extrapulmonary is around 5 to 10% only, but I'll be just telling what are those. And in the pulmonary, I would be speaking on the CORADs, then what are the CT severity index on the HRCT chest, how to look at it. And the most important topic is what are the COVID mimics and the coexisting disease. Because the COVID mimics are the ones which you will, think of the other diseases which can mimic like COVID, and that is responsible for overdiagnosing the COVID. I will be giving what is a COVID follow-up on HRCT. And in the last few minutes, in the third part, I will discuss what is HRCT vis-a-vis the RT-PCR test, what is a radiology perspective. So just this is one slide to discuss what is a multi-center. We are involved in the multi-center study of the COVID-19 because this is a multi-study for all over India. For all patients based in Chennai, based in Bangalore, based in Thane, based in Chandigarh. Thane has been selected because it was a hotspot for COVID. We were, as Dr. Sujata said, we were doing around 50 cases of HRCTs and 50 cases of X-rays way back in September and August when the COVID was at the peak. And this study, what we are going to do is to assess the CT appearances of chest and to look at the patients from all over India, assess the temporal changes in pneumonia over time, assess severity score and its relationship to the clinical and laboratory parameters, and assess the differences between the symptomatic or asymptomatic patients of pneumonia and what are the HRCT findings. So we'll be a part of this multi-institutional study at all India level. So to the first part, what are the logistic issues? Now, to know for radiology is a 24-hour services. And I remember that is on the March of 22nd when our Prime Minister Narendra Modi, he introduced the lockdown. When I came to the center the next day, I work at the Jupiter Hospital also, and I work at the center. At Jupiter Hospital, at least some of the staff was present, but at the center, there was only one single boy who was there. The whole staff was absent. There was a lot of apprehension. Even the boy was there because he was staying at the center and he couldn't go anywhere. That is why he was there. And the other thing is our center is open 24 hours by 365 days. And actually, though we have a shutter, we don't have the locks. So he couldn't go. That is the reason why he was there. But he was so apprehensive that he was asking what will happen to me and what will I die and something like that. So there was a lot of apprehension and everything was closed down, which had happened first time in the last 25 years. But slowly then we got to working. We started developing work for only 3 hours, 50% of the staff. We had to develop radiology protocols with the staff PPE, with the staff was wearing PPE, masks, and then maintaining social distances of the patient. All the department and machine sanitization was done. With this, the staff, with that also there was some staff infection, and then we realized that the staff infection was not because of the staff at the center, but because they used to travel outside and the social interaction gave them the infection. But then because of it, there was absenteeism, and we used to get daily unique logistic issues complicated due to changing directives of the local municipal authorities, saying that if there is an exposed personnel, then they used to do a contact tracing, and all the people involved used to go on leave for about 2 weeks for quarantine. So it was very difficult to manage a center, in such circumstances. And the staff was so apprehensive, so there was daily staff counseling and protocol modifications. So basically, this is how we were working. This is myself working in all the PPE with the head shield and with the mask, with the head cover, and with the gloves. So it's very difficult working like this more than 6 to 8 hours. This is our sister in working in a CT scan machine with all these gloves. These are all our paramedical personnel, so they had to maintain the distance. But in the last 7 to 8 months, we have observed that if we work like this, even if we are doing about 15-20 COVID patients and we sanitize the machines properly, then none of the staff was getting infected during work. So to come to the second aspect of the lecture, that is what are the COVID features, HRCT features. The main thing are the pulmonary. 90 to 95% is pulmonary. Only 5 to 10% would be the other systems. So in pulmonary, the main thing what we see is the GGOs, that is a ground glass densities, bilateral patchy and subpleural. Sometimes there can be confluent areas of consolidation. Sometimes can be linear bands or atelectasis. Sometimes the sequelae of COVID can be seen as a residual interstitial scarring. The pleural effusion, mediastinal lymphadenopathy, and pneumothorax are uncommon. So if they are there, then the less chances of it being COVID. The modalities available for the radiology are the X-ray. The X-ray can be indicative, but early changes, it can miss the early changes. So even if the X-ray is positive, there can be minor changes and you have to do an HRCT chest. Or even if the X-ray shows bilateral changes, then also to stage the disease, you want HRCT. So HRCT plane is very sensitive and the modality for COVID patients. Ultrasound and MRI, they have got a limited role in extrapulmonary manifestations. So this is an HRCT, this is an X-ray chest in COVID. See, these are the ground glass changes which are seen at the periphery. Again, some ground glass changes, but these are very subtle and can be missed, and ultimately you may require HRCT. So this is a HRCT chest in case of COVID, and these changes are very classical. You can see the subpleural changes. So if this is normal, these are the subpleural ground glass changes. You can see the subpleural ground glass changes. You can see it bilateral. So these are called as a ground glass GGOs, and they are bilateral. They are more peripheral and subpleural. So these are very classical changes of COVID. So what you see in these patients are, you see a vascular tree in bud. So this is a vessel, and this vessel is thrombosed, and that is why it is prominent, and because of which there are certain areas which are seen here. This is called as a vascular tree in bud. Usually an infective endobronchial disease, you see a bronchial tree in bud appearance, but this is a vascular tree in bud appearance, which is very classical of COVID. If you see this changes, it is more of a COVID. Then there are sometimes you see these subpleural bands, actually subpleural bands beneath the pleura. So these changes are very classical for COVID. Then these are certain other areas where the disease is more, when you go into subacute stage, that is 5 to 10 days, these are the areas, they will get more mature and you get these subpleural bands. So this is kind of a mature COVID. So this is early COVID, very early in the first 1 to 5 days. And this is a slightly mature COVID. But if the COVID becomes more, more severe, then you can get confluent areas of consolidation. So this is a resolving COVID, whereas this is more progressive COVID. So there are confluent areas of consolidations and bilateral. This is again a patient with positive PCR and bilateral GGOs due to the coronal deformations. And see, this is a very classical called as a halo sign, where you can get something, then there's a lucency here. So basically the lung changes which happen in COVID are not because of the infection or not because of the pneumonitis, but it is because of the perfusion, because if there is this vasculitis and there is vascular thrombosis, the lung parenchyma does not get the blood. So there is hypoperfusion. Then as in the brain, the surrounding tissue gets luxury perfusion and then hyperperfusion. So this is the hypodense area, the line which you see is the hypoperfused area, and then there is a luxury perfusion sets in, so there is hyperperfusion. So this actually causes a halo, or it can be a reverse halo or a halo, and this causes this ground glass changes. So it's not the direct infection. Initially they were thinking it's direct infection, but later they realized that it is the perfusion, hypoperfusion and luxury perfusion which are causing this lung changes. So in HRCT chest, they developed something called as a CORADS, which is a full form is a COVID reporting and a data system. It was established in March 2020, Standard Reporting Working Group of Dutch Association of Radiology. They introduced CORADS, and this was done to ensure CT reporting in a uniform and a replicable manner. So you have CORADS 0 to 6. So all the radiologists or all the clinicians, they are on the same page as to know what is the disease status. So CORAD 0 is that CT is uninterpretable, and then CORAD 6 is RT-PCR test is positive. So here they are the CORADs. They describe the levels of suspicion of the COVID-19 infection. So if you have CORADS 1, means there is a normal or non-infectious abnormalities. Whereas if it's a CORAD 6, means it is RT-PCR positive. Remember that when you have RT-PCR positive, the lungs can be either normal or they can be positive. So it can be, you just say if it's RT-PCR positive, it becomes CORAD 6, not depending upon the CT findings. Then we have a CORADS 5, which is very high probability. So it's typical of COVID. Whereas CORADS 2 is very low probability. That is, abnormalities are consistent with infections other than COVID. If you have a COPs or other pneumonias, then it is CORADS 2. But this CORADS 3 and CORADS 4 are the one which are very important, because the findings are indeterminate. They are unclear whether COVID is present or not. Again, CORADS 4 is a very high probability. So this is the region, these are the areas where, in the initial days, when the CORADS was very high, they were reported as COVIDs, and that was the reason why the CT reporting was over-reporting of CORADS was done, and we need to see why it was done and how to avoid it. So this is CORADS 2. If you see in the lungs, these are only some infiltrative changes here. So we know that it is just a small infection, not a CORADS. Whereas these are unilateral and a dense consolidation. This is a chronic organizing pneumonia, COP, what we call it, and not a COVID. So we call this as CORADS 2 and very low level of any CORADS infection. Whereas this is CORADS 3. CORADS 3, you see here, there is a ground glass density here. So this is ground glass, but it is not peripheral, or it's not subpleural. This is along the fissure. Again, here there are some ground glass areas here, or again here. Then again this areas. So this area, they are not very classical of COVIDs, but this is indeterminate, and you should be careful to label it. So all kinds of bronchopneumonias, lobar pneumonias, or septic emboli will give these ground glass opacities. But some people who are not, if you don't have a proper history, or some radiologists may label this as a CORADS 5, and then the patient may have treatment, and the patient may be also, the apprehension is also more for the patient, because it's detected as a COVID when he's really not. So we have to be careful for this CORADS 3. Even in CORADS 4, the level of suspicion is high. For example, in this case, if you have a unilateral case like this, where there are ground glass changes, they are not bilateral, they are not subpleural. So here, but still in a high chance, whether you can really rule out COVID, we don't know. So this poses as a clinical dilemma. For example, if this is a kind of patient and he wants to undergo surgery, like we had one case, like she was a female and got these changes, and she has to undergo a left ovarian cyst operation. Now with these changes, can you be sure that it is COP and not COVID? So then whether they want to really operate, the anesthetists are very fearful, because they will be exposing the surgeons, anesthetists to COVID infection. So in such cases, when it is COVID 4, this is COVID 4, then you have to be, what we do is generally we tell the patient or we tell the referring doctor that these are the changes, and probably it may not be COVID, but we are not sure 100%. So in such cases, if the surgery is not really indicated, not emergency, then they can wait for a couple of weeks, maybe see for the symptomatology, maybe after a week repeat RT-PCR and see. In this case, the RT-PCR was negative, but these changes were there. So nobody could take the guarantee whether they are 100% not COVID, and the anesthetists were really afraid to intubate and do the surgery. If the surgery is not very critical, then they can wait for 2 weeks. Then we repeat the RT-PCR, see for symptomatology, and we repeat. If it is COP, patient on steroid, this disappear. And if it is something like NSIP or something, they won't disappear. So that is how we are. This is how we can triage the patient based on the CT findings. Another case where there is the interstitial lung disease, but there is some ground glass changes here. So whether it is a COVID superadded on ILD, we are not sure. So in such cases, we can be careful. So CORADs 3, CORADs 4 are quite indeterminate, and we have to be very careful. Whereas this is CORADs 5, you get multifocal GGOs, bilateral, then you get this vascular trine bud appearance, we get this subpleural bands, and we are very sure that this is COVID. So this is the whole spectrum: CORADs 2, CORADs 3, CORADs 4, CORADs 5. So this is to see that if it's 2, it's non-COVID. If it is CORADs 5, it is definite COVID. And if it is CORADs 3 and CORADs 4, then you have to be careful. And again, to tell that this CORADs is not the ultimate, it also depends on what are the clinical features of the patients, and across the radiologist also how experienced to give the CORADs. So you have to be remembering that too.